I'll just start all over. Welcome to session 3A, titled eHealth 1. In this session, we have 5 presenters, and they're going to present to us a number of different issues related to health. Our first presenter is Dr. Olumayowa Ogundayin. He is with UNISA Graduate School of Business Leadership here in South Africa. Dr. Ogundayini's research interests include health informatics, design of health interventions, and social implications of digital transformation to the sub-Saharan communities. Currently, with his colleagues, they're collaborating with University of Leeds in UK on global security perspective. And his paper will highlight to us the importance of digital health leadership, and it actually attempts to conceptualize it within the sub-Saharan Africa health system space. Dr. Ogundayin, please.
Thank you, Chair. Thank you, Chair, and good afternoon to everyone. First, I would like to start by highlighting the motivation for this paper. And it was informed by the WHO's document on the health systems for health security around the world, where they came up with 6 pillars that are needed to strengthen a health system. And looking through those 6 pillars, just trying to see how Africa, the sub-Saharan African region, is doing in that aspect, I realized that the leadership aspect is lacking. And that is what has informed this paper. And also, while listening to the speakers today, I was trying to pick out the role of leadership in how technology is designed, in how technology is rolled out, but that key element is missing. And that's one of the things I'm hoping that my paper is able to lend some clarity to, or at least start a conversation on. All right, so in terms of leadership, the role of leadership within health systems, right, it's to mitigate against the effects of ineffective management, poor governance that leads to a weakened health system. And like I rightly mentioned, when you look at the 6 pillars of the WHO health systems for health security, technology and leadership are 2 of those 6 pillars. So what that tells us is that e-health leadership, okay, is at the core of building a resilient health system. Unfortunately, not much has been done to conceptualize what e-health leadership means within the space of sub-Saharan Africa. However, there are existing studies that look at leadership and management within health systems. In the studies that look at health leadership within the health system, leadership has been categorized into 2, which includes political leadership and technical leadership. And in terms of political leadership, that refers to the personnel structure that is responsible for the budget, the investment, and creating an enabling environment for digital health to be designed and implemented. And examples of political leadership would include the Minister of Health. For example, the Minister of Higher Education was here today to open. He is also very much interested in how innovations and technology are rolled out within the communities. So these are examples of political leadership. We also have policymakers, we have health agencies, and Also, moving on to technical leadership. Technical leadership looks at the academic experience, the competencies that are necessary to design, implement, and evaluate digital health interventions that are rolled out. So these two concepts are the fundamental concepts that e-health leadership can be conceptualized on, and I think that's one of the things I attempt to do in my paper today. I looked at a recent paper by Karamagi et al. 2022, where they look at health interventions in sub-Saharan Africa. And if you look at the statistics that they provided, leadership and governance is at the least, the bottom of the pile out of all the health systems building block. So this also serves as one of the motivation for looking at how the WHO framework, the National Digital Health Strategy of countries, and articles, academic articles have looked at the issue of leadership within health systems. So the objective of my paper was to look at the status of e-health leadership and also to try or attempt to contextualize e-health leadership concepts that are relevant to strengthening health systems in sub-Saharan Africa. So I conducted a rapid review, and the reason why I did a rapid review was to have a quick bird's eye view of what exists in literature around digital health leadership. And to do that, I looked at scholarly articles and also available national policies or strategies, depending on the semantics that are used. Some call it the strategic plan, National Health ICT Strategic Plans. I looked at those documents online. And then in terms of looking at data online databases, academic journals, I looked at Google Scholar essentially because of its wide indexed articles, and then used the and or logic to search for relevant articles using keywords such as e-health or digital health, leadership, and sub-Saharan Africa. And then I looked at the available national e-health or digital health ICT policies that were available online. And I must say, in order to, the reasons why I looked at the national policy was to look at if there are leadership competencies that are involved in those documents or if there are capacity building provisions in those documents. And in terms of the articles I looked at, the type of e-health did not influence my result because I was focused more on the e-health leadership. In terms of my results, what I found was that out of all the countries in Africa, at least 26 of those countries had an e-health or digital health strategy. And I've tried to list those countries where they mention e-health leadership or e-health leadership capacity building, all right? Although the extent to which they've operationalized these provisions is not yet known. And in terms of screening articles online, there are only about 4 to 5 articles that were eligible where they mention e-health leadership or competencies. And these are the articles. In terms of discussion of my results, what I was able to establish was that the literature on e-health leadership is limited, and the limitations can be attributed to the staggered way in which e-health is being implemented in various countries in sub-Saharan Africa. Also, the slow implementation or operationalization of national e-health policy documents. So these are what I attributed to the limited literature on e-health leadership. And then also, in terms of the staggered implementation of the e-health national policies, two of the reasons attributed to that is the limited resources and limited capabilities or capacity that currently exist within the health systems in sub-Saharan Africa. And of note is to mention that there are quite a lot of digital interventions also that have been implemented. However, most of them are duplicated and they are not particularly focused towards strengthening service delivery towards health security in the health systems of sub-Saharan Africa. And then another thing that literature revealed was that healthcare professionals are known to take on leadership and management roles, but when it comes to e-health competencies, there is still a lack. And right now, when we talk about digital economy, we're talking about the use of artificial intelligence, big data analytics to make decisions, and in order to participate within that digital economy and to realize the potential of e-health, leadership is very important. So based on to summarize the concepts that came out from literature, I attempted to conceptualize what e-health leadership should look like within sub-Saharan Africa health systems. However, this needs to be subject to empirical studies. So I conceptualized e-health leadership as the act of a competent individual. So now here we're looking at the technical leadership aspects or group with relevant and ICT or ICT digital skills and knowledge, combining both political and technical leadership in taking the lead to ethically implement and evaluate technology-driven health solutions. The leader develops operational plans with a multidisciplinary stakeholder team, establishes mentorship as a means to share knowledge, institutes accountability measures, and is responsible for managing and motivating other personnel to address health-related challenges peculiar to a certain context. As we all know, one of the things that digital transformation is revealing is that not one size fits all. Context does matter. Consequently, this combined individual and organizational skills and competencies translates to the realization of a strengthened health systems that boast of enhanced quality service delivery, a skilled technology-oriented workforce, leading to universal health coverage and improved health outcomes. So in order to gain the benefits of digital health intervention, it is important that e-health leadership comes strong. To conclude, my paper attempts to address the literature gap on contextualizing e-health or digital health leadership in sub-Saharan Africa health systems. I recommend that policymakers and governments should incorporate the objectives of e-health leadership in their national health policy documents in order to build capacities, in order to identify competencies that are needed within the health system, and also to incentivize short and long-term leadership courses in digital health for relevant professionals to upskill and to enable capacity development. And finally, one other recommendation is that there is a need to operationalize e-health leadership in the context of the different variables that influence what e-health leadership is. For example, it could be culture, it could be political interest, it could be profession, it could be gender. In terms of the references, some of the references I used, they are there, and I've also expanded more on the paper, which is hopefully going to be included in the proceeding. Thank you very much for your audience.
Thank you very much. Maybe we have some questions for... Yeah, thank you very much. If we have some questions, comments, I'll take two for now, and then we can have the rest at the end. Is that a question?
Yeah, I have a question. Thank you for your presentation. I don't see in your references documents from the World Health Organization. seems a little bit.
If you look at the third bullet point to the last,
Okay.
yes.
Just monitoring the building blocks.
All right. But if it was not on the slide, I'm sure it's in the paper.
Yeah. Yes, sir.
Thank you very much for the nice presentation. I'm wondering whether you also checked the digital maturity of the continent, considering that the health sector is a specialized field, so that if changes are going to happen in the health sector, they should have started, I think, from other applications which are not like specialized, that are not highly regulated. So what is the level of digital maturity in the continent?
All right. Thank you for your question. In terms of looking at the digital maturity level, I didn't consider that. However, like I mentioned, one of the motivations for this paper was to look at the building blocks towards realization of strengthening the health systems in sub-Saharan Africa, of which there are 6 of them. And if the health systems are strengthened, it means that we all have health security. And hence why I focused on those 2, which is technology and leadership, as where we are lacking behind. Yes, we have the ideas of what technology can do, but we are lacking in the leadership competencies and the skills capacity to ensure that we coordinate and we bring together these 2 concepts towards realizing health security.
Okay. We'll have that question as the last one for now, and at the end, we'll also have a set of questions from all presentations. Yeah.
Thanks very much, and thanks for that great presentation. Really a very important topic as well. Just to say again, based on what the other colleagues have said as well, I think there's a lot of information in the maturity assessments work that has been done by various organizations that may be a little difficult to access, kind of grey literature, but a lot of assessments have been done, sort of maturity assessments, like I'm thinking of the stages of continuous improvement, that the so-called SOCHI work that's been done, and then also there's work that the CDC has done, CDC Africa as well, on the informatics savvy organization, where there's a lot of information around the technical competencies in those areas measured at national and subnational level in a number of African countries. Just a thought.
All right. Thank you very much for that.
Thank you very much, Dr. Ogundaini. Let's give him another round of applause. On stage, I will now call upon our second presenter, and that's Professor Mohamed Jamel. He's from Association de Technologie du Centre from Tunisia. His research interest includes software engineering of distributed systems, formal methods in model-driven architecture, self-adaptive and pervasive systems. He's been involved in many research projects, vast experience, and over the years he's published over 300 regular and invited papers in conference proceedings and journals. He has co-edited 6 conference proceedings and co-edited 5 journal special issues. So much experience. And is also currently a leading principal investigator in the EU Horizon 2020 Better eHealth project, and also another EU project called Net Unit project within the IEV program. Over to you, Prof. Jamel.
Thank you, Shipu, for this presentation. So, my name is Mohamed Jmail. As you remarked, so my background is computer science, and I'm actually professor at the University of Sfax And today I'm representing the Cluster Health Tech. Actually, the Cluster Health Tech is an organization at the regional level which aiming to set up an ecosystem for building or for building innovation, creating innovation and entrepreneurship in the region. It's facts, because we are very convinced that health technology, and particular digital and e-health, is an opportunity not only for Tunisia, but all for the continent and for all the world. It's not only about health, but also about economic challenges and opportunities. So, as I said, today I will present so best practices and lesson learned from e-health projects carried out in African countries, particular 4 African countries, which are Ghana, Ethiopia, Malawi, and Tunisia. And these countries are actually partners, the African partners from this project, the Better eHealth project. And the Better eHealth project is a European EU-funded project under the framework of Horizon 2020. And it is about digital health and aiming at providing support for decision makers and stakeholders in order to make successful digital health transformation in Africa, and particularly in the participating and partner countries. So the Better eHealth project is built on, let's say, 3 or 4 work packages. We are focusing on human factors, on technical factors, but also on political and ethical or policy factors. And in order to do all this work, because the main objective is to provide to decision makers some kind of roadmaps and strategic plans in order to facilitate the digital transformation of the health sector in these countries. And to do this work, because there's many data collection and analysis should be done, we have a whole work package which is dedicated for collecting data about policies and solutions developed in these countries. So the overall objective of this project is the e-health in itself is not an objective, but is a tool in order to provide a better quality and accessibility of health services. So the main objective of this paper is we have 2 objectives. The first one is to investigate existing e-health projects in these 4 countries, notably Ghana, Ethiopia, Malawi, and Tunisia, in order to identify best or good practices, but also lesson learned from projects dealing with digital health, and identify critical elements to the success of e-health in these countries. So we think that we have to avoid creating or so we think that building on already our previous experiences, particularly successful experiences from other countries or within the countries, is very important in building digital health systems. And you know, building digital health system is a very difficult task, and should be also made based on, among others, already successful previous experiences. So we are dealing with Okay. So we focus on e-health projects. It could be solution, policies, intervention, procedures, and we try to identify best practices. I will show you how we can, or how we would qualify a project as best practice and what kind of lessons we can learn from these projects. So the objective is to assist other parties within similar context, or how to build reliability to the desired results, how to improve outcomes, and avoid particularly some mistakes in building projects, because experience could be successful, but sometimes there's some failure, so we can learn from this mistake or from this failure. And yeah, as I said, we are trying to avoid reinventing the wheel, and to avoid also mistakes in order to build scalable, sustainable, but also more effective digital health project. So how to do that? What we try to do, we try to make this this process as formal as possible, and we try to base on some kind of indicator to do this evaluation in order to classify or qualify projects as good or best practices. So the first primary evaluation is based on Global Digital Health Index. So one of the difficulties we encounter when we deal with this kind of work is collecting data. Collecting data is not a very easy task, and to do that, yeah, we try to look on the web, on papers, and so on. And one of the resources we use it is the Global Digital Health Index, and this is a platform provided by the World Health Organization, and it provides indicators. These indicators monitor and evaluates the progress of the digital health transformation in one country. And it is based on the 7 pillars of the, let's say, digital health system in one country, which are leadership, strategy, legislation, workforce, people, human resources, standards, interoperability, infrastructure, application, and services. And each of this component is evaluated. So the maturity of this component is evaluated according to a 5-scale indicator from 1 to 5. So 1 indicates a very low level, and 5 indicates very high level. So if we get number 5, it means that the component reach its maturity. So I give you an example from here is the Ghana, for example, the Ghana health system. The overall is, the progressing is phase 3. Leadership and governance is 3. For example, from the strategy investment level is level 2, and so on. Another level of evaluation is we set a set of criteria, and these criteria are classified in 3 classes. So we have exclusion criteria, core criteria, and qualifier criteria. And these criteria are so taking in a project, a health project, we try to evaluate this project according to this criteria. If one of the exclusion criteria is not satisfied, so we cannot consider this project or this intervention as good or best practice. So in order to make this evaluation, we for each criteria we set up a set of questions in order to be able to attribute a score for this criteria. So, for example, for relevance, we have asked to what extent does the intervention or solution address the identified needs? How well do the objective of intervention correspond to the needs of the end user, and so on. And we built for that formulas, and doing that we need to collect data. Data collection is based on desk research and document reviews, on also surveys, on papers, and on the web. We had also focus groups to discuss with people, particularly people in Ministry of Health or people in Ministry of ITs involved in the digital transformation process. So we had also interviews with people, with representative of these ministries. So doing that, we or based on this criteria, we were able to identify some best practices or good and best practices. Two solutions in Ethiopian. One in Ghana is about a policy, two solutions in Malawi, and two solutions in Tunisia. So all these results are based on data collection, as I said, and data collection are not easy to make, since each partner in the corresponding partner country made their effort, many effort, in order to get and to obtain data from representative, and to get the formula filled, and to be able to evaluate them according to the criteria I presented. So, for example, solution from Ethiopia is the digital, is the district health information system, which is a software aiming to improve monthly reporting of indicators in order to facilitate decision making in these countries. There is also electronic community health information system in order to involve people, particularly end user, but also community of patient in the digital health transformation process. In Ghana, for example, we identified the strategy they built and how they built the strategy, and particularly the regular framework, and also the skills building or the training in order to make capacity building of professional of health, of the health sector. So what we can learn from this solution, or from these best practices, is we can, just one second. So from the Ethiopian e-health system, evidence-based performance indicators are very important to set up. Participation and inclusion of all categories of stakeholders is very important. To have also from the Ghana system, we can learn that it is important to have policies, but also a complete legal framework. And when we don't have a legal framework for e-health, it could be an obstacle, or an obstacle for making or for adopting e-health solution in these countries. From Malawi, for example, we can learn that interoperability is very important in order to be able to integrate health information systems, and also making a solution based on human-centric design is very, or following a human-centric design approach is very important. So besides the, let's say, the successful of many solutions that already developed and deployed in African countries, particularly in the 4 countries we studied, and we can identify some challenges in relation with digital health projects. So we observed that most of the projects are pilot projects. So sustainability is not always ensured because it is not based on the big picture or a whole transformation process of the digital system. Also, we observed that few innovation and because the lack of collaboration between health professionals, but also people from the technology sector. So and another aspect is the lack of innovation and entrepreneurship ecosystem is also one of the challenges. We observed that most of the running projects and also past projects have been funded by foreign donors, so there is little investment or national investment in digital health in African countries. So we can conclude that regarding the factors I presented at the beginning regarding the beta e-health projects, so participation and inclusion of all categories, stakeholders is very important to build the strategy of a country. Transparency is very important, sharing also the strategies, and regarding or taking the whole process from the beginning. We think that regarding technical factors, working with open source codes is very could foster innovation and could provide many solutions for digital health transformation in Africa. Having evidence-based performance indicator and monitoring tools is very important, and interoperability and standard-based solutions are also very recommended. Is sometimes mandatory or obligatory. Human factors, so capacity building is very important, and user-centric design is also paramount criteria when dealing with digital transformation of the health sector. So thank you very much.
Thank you very much, Prof. Thank you very much. I'll ask participants to take note of the questions for his presentation, and I'll open at the end because we spilled over in terms of the time. I'll now call upon the next presenter, Dr. Thank you so much, Prof.
Thank you. Shipu is from East Malawi, is also one of our partners in this project.
Yeah.
So we have here the booklet of the project is in French. We have also an English version. If someone wants to have the English version, please email me this.
Now that you mentioned me, there's a lot. Actually, there was a question on maturity. As part of the project, we also did maturity assessment for standards and interoperability across the 4 countries. So there's a lot which can be learned from the booklets. Thank you. Yeah. I'll call upon Dr. Wegene Demek. He's from Edinburgh Napier University in the UK. Dr. Demeke is a lecturer and program leader in the School of Computing Engineering and Built Environment at Edinburgh Napier University. He has taught at various UK universities, including Brunel University, Cardiff Metropolitan University, and Bucks New University. His research interests include adoption and use of technology in education, hospitality, and health sectors. He's published his research in peer-reviewed journals such as ASLIB, Libri, and Computer Applications in Engineering Education. Let me call Dr. Wegene Demeke on stage, please.
Thank you very much. Just before I start, my area of interest in my research is in terms of ICT adoption and use particularly in developing countries. So let me just start my motivation. This is a sort of problem-driven motivation. The health service provision in Ethiopia is very, very, as you can see, is as low as the 10% coverage in some areas. Even in the capital city, the coverage area is about 50%. There are a series of barriers, geographic barriers, limited infrastructure, health professionals, particularly in rural areas. People want to work in cities where there are a lot of services for their families, so they're not really interested to go into the remote area of the country to work. The systems is not really strong enough in terms of the infrastructure, so the referral systems are very weak, have got really a whole impact on the health outcomes. So, but in terms of rapid advancement of technology, specifically telemedicine, there is a whole lot of promises that might really help to really change in that. There are two objectives which I was looking in terms of it. One is the normal, what are the barriers in terms of the implementation of telemedicine, health provision. The other one is these are in terms of organizational technical barriers, which comes in terms of knowledge factors, where people don't really have the knowledge. So the health policies are the one which I was looking into as well. So are these policies, as Professor Mohammed was talking about in terms of these policy issues in different African countries, is there any differences in terms of these policies resulted in different outcomes of e-health? One of the questions is that. So, but my focus is when I'm looking in terms of these policies in Ethiopian perspectives, this is regarding about what are the policies that really drive telemedicine, especially where the population, the lot of population, that is 80% of the population lives in the rural and unserved areas of the country. So in terms of that, so what happens is the research approach is to really know exactly what are the barriers, went to the health professionals and do a survey, both qualitative and quantitative data. And what happens, what I did, another one is I collected the available health policies, and as these health policies are really enabling or become a barriers themselves. How often do we actually look at our policies, whether they are really fit for purpose? As you know, the policies really run every 5-10 years. Technology is advancing at a very fast rate. Are we really using these policies in terms of it? But particularly my interest was, as these policies harmonized, which comes out from different ministry offices. So the innovation minister has got their own policies, the health minister has got their policies, the agricultural minister has got their own policies. So I'm looking at how are these really harmonized? Do they really give the things that we are really looking to get the outcome of it? So the result, what happens is now the major outcome, the outcomes which results, which I've seen is there is a lack of technology infrastructure, lack of training experience, because there is no much in there. You can't really get experience and knowledge, and lack of awareness and management support. It is, when you look at considering telemedicine, it is a sideshow. It is not considered as one of the main means of delivering healthcare, especially for the people who are really living far in terms of the countries. You look at in terms of the policies, the different policies are not harmonized, and this really creates that there are policies which are looks as if they are wish lists rather than implementable in terms of providing actual outcomes in terms of the health outcomes of the population. So these are in terms of, there are already established telemedicine services, you can actually see that the current data which shows the 388 consultations done in 5 years. That is there are about 46 hospitals are using telemedicine. You can see that it is not actually used as significantly as it is supposed to be. Okay, so this is really big impact of the outcomes. Just but to give you the background, this is the Ethiopia. The geographical really differences is really huge. The division between the highland and the lowland, where the Rift Valleys goes through it, the highland is, the roads are really difficult because it is a mountainous area, and the highland, the lowland is just sparsely populated. So it is that the technology are not really difficult. Even though Ethiopia started way back, this is Lunadingle, one of the kings who lives back in 1508, brings the modern hospital from Portugal, established a hospital in Gondar. That is the place where he was the king, and then he works in terms of it. But the available data, you can see, indicate the health system coverage in Ethiopia is still 34.3%. So looking at the capital at 52%, and the Afar region as low as 10%. So here, technology advances, there is a great potential in terms of the improvement of quality of care. There is always a shortage of health professionals. When I really look at in terms of health professionals, there is always one African-trained doctor leaving Africa to Europe every day. It's 365 days a year. So what happens is, yes, in terms of AI, we don't know really the impact of it, what it's going to create in there, but the health professionals are not really available in terms of the. So telemedicine can provide equitable, equality healthcare systems, but it is not actually recognized as one of the way to provide health services in the country, especially for people who are really living in the remote areas. So this is reduce barriers, harmonized policies. This is one of the key elements of it in terms of it. The policies are not really harmonized. There is no really how to implement that policies when you really look down deep in there. In terms of accessibility, it might really increase. And then some of the new AI technology might really help the implementation of the technologies to really improve the health outcomes of the population. Thank you very much.
Thank you very much. Thank you very much, Dr. Demeke, for that presentation. Again, we'll take note of questions to this presentation, and we'll have a round of question and answer at the end. I will now call upon to the front our next presenter. Our next presenter is Belina Shisia. She works with Ministry of Health in Kenya, and today she will be presenting to us a paper titled Implementing a District Health Information System during the COVID-19 pandemic, a stakeholders approach in Kenya. And this will focus mainly on the challenges of deploying digital solutions for data management during public health emergencies. Her interest is on confidentiality, data security, and governance within ongoing digitization and automation taking place in the Ministry of Health in Kenya. Over to you, madam.
Okay, thank you. Good afternoon.
Good afternoon.
The motivation of this study was that many countries are implementing digital platforms for managing routine data. But when it comes to public health emergencies like COVID-19, they did not do very well, especially for Kenya. So that was our motivation. Quality data cannot be underscored, especially in emergency situations. Now, a number of countries, including Kenya, we have Mozambique, Sri Lanka, among others, including Rwanda, adopted the District Health Information System, DHIS2, which is an open source, a free open source platform that was developed by University of Oslo. And Kenya has been using this platform for routine information. Now, when COVID emerged, there was a module that was customized to be able to collect the necessary data. However, it faced challenges, forcing other data collection channels to be employed. So that is why we wanted to understand why this system did not perform well. Our objective was to gather experiences in the implementation of DHIS2 in a pandemic situation, and specifically we wanted to assess the robustness of the DHIS2 package in regard to its accessibility, simplicity, flexibility, data quality, and facilitating conditions. We also wanted to understand the existing legal and governance framework for adoption of DHIS2, and also evaluate stakeholder engagement during the implementation of the software, or the utilization of the software for managing of the COVID-19. Our design was longitudinal case study design, which was best suited to answer the questions of why and how. Why is it that DHIS2 COVID package did not work well in Kenya? We collected data at the national and subnational levels. That is, at the national level, we had departments that were key to collection of this information. That is Department of Health Information System. There was the Emergency Operations Center that was set up to manage or to handle COVID issues, and also the National Laboratory Services. At the subnational level, we sampled 8 counties from high burden, mid, and low counties, low burden. And then, due to COVID restrictions, our sampling method was convenience sampling. We had to target a group that was easy to obtain because of the restrictions that existed. Now, we reviewed documents and electronic systems and conducted key informant interviews. We also used a standardized questionnaire to conduct interviews, and we evaluated the DHIS in terms of simplicity, flexibility, acceptability, data quality, and facilitating conditions. Of course, ethical clearance was sought, and participants gave their consent. The interviews were transcribed, and an analysis of the emerging themes constituted, and this was discussed with participants in order to gain in-depth understanding. So the results in regard to simplicity of the systems, most participants or the respondents found that the system was simple to use. That is the DHIS module, which was customized for COVID data, was simple to use. Data entry was easy, but data analysis became a challenge because there were gaps. There were gaps in that led to misinterpretation of data. Then we had the health records and information officers who routinely reported on, who always reported on DHIS, on routine data. They were better placed to utilize the system than other cadres. In terms of flexibility, COVID, the module could only accept data for COVID-19 and not other diseases. Then DHIS track, especially when we wanted to to check on how HIV relates to the COVID-19. That was a challenge when it came to analysis. DHIS tracker module that revealed client identity made it difficult to allow access to stakeholders. There was a challenge in terms of who should access, who should be given the rights in regard, because of the issue of confidentiality. And because also there was the changing needs, like initially there was no vaccine, but then later on after some time, we had to start reporting on the number of people who are vaccinated. So it required again another module that was developed, which was outside what the DHIS2 was. And then because of this inflexibility, there were other ways in which data was collected, and that meant that the module, the DHIS module for COVID-19 data was actually abandoned in view of the simpler methods like use of the Excel sheets. In regard to acceptability of the system, DHIS2 reporting was accepted. Stakeholder engagement was poorly done, especially at the beginning, because when the need came to have the COVID data collected through the DHIS2, it was the developers plus the government bodies that came together and did the customization. Then there was limited updating of the system, in that, routinely that system, it was capturing routine data was, you will take all the time to be able to do the data entry. But there was an urgency in regard to reporting of COVID. And therefore, you will find that some counties will not have reported, others have reported. When it comes to the national level reporting, that becomes a challenge to be able to generalize that information and say these are the cases from the country. And because of the also workload, there was the routine, work that needed to be done. That now meant that even narrowing down to collection of COVID-specific data became now a challenge. Data quality. There was a challenge on the information that was collected. Sometimes you'll find that the phone contacts was a challenge. Accuracy in terms of the dates that were reported, there were discrepancies for instance, a person will be asked which county do you come from? The person resides in Nairobi, for instance, the capital city, but then their home is in another county. So you'll find that when it comes to analysis, where do you place this person? So things like that. Then data validation issues, it was also possible to enter. That is now a system issue whereby somebody will enter a person with an age of 2,000 years, which wasn't really accurate. So there were facilitating conditions, although they were not enough to sustain to make the system successful, was that participants in the study were adequately informed about the DHIS2. There was training that was conducted, and even counties also embraced the informal learning. They formed the WhatsApp groups, and they were able to share knowledge. And most counties also had access to computers and internet, except for a few areas like Wajir. Now, DHIS 2 has most of the necessary support and technical capabilities for COVID-19 management. That is what we really found. And we know that, of course, there were limitations in terms of data quality, flexibility, acceptability, but a major challenge was in the stakeholder engagement, because it was difficult to coordinate the stakeholders with different interests. For instance, the national government had an interest in ensuring that data is collected from all the counties. Sometimes when cases are reported at the county level, because of fear of being fear of lockdown and affecting a specific county, you'll find that leadership in that county say, no, this is not the data that we have approved to come from our county, and things like that. So data governance was another challenge. So as I had mentioned earlier, there was access was denied to some of the stakeholders because of the confidentiality issues. So in conclusion, this paper identified the pivotal importance of establishing adequate stakeholder engagement and maintaining mechanism of learning and collaboration among stakeholders during emergencies, especially in the initial period of customizing or coming up with a package for reporting. And also, for successful implementation, we recommend adequate stakeholder engagement and change management activities such as training. And of also greater importance is rapid system user evaluation. Could this COVID-19 reporting tool have undergone evaluation earlier on? Probably that will have been a success. Thank you.
Thank you very much, Madam, for that presentation. We move on to, last but not least, online for this session. We have Dr. Chris Sebret. I'm not sure whether I've got the correct pronunciation. Dr. Chris is based here in South Africa, but he works in many African countries. Also, he works in Indonesia. He's part of the South Africa Department of Science and Innovation Center for Artificial Intelligence Research. He is the founder and CEO of Gembi Health Systems, NPC. This is a South African NGO focusing on digital health and health data science. He is also an honorary research assistant in the School of Public Health at University of Cape Town. At University of Cape Town, he is also an honorary research associate in the School of, an associate, research associate in the AI research, plus other responsibilities. I can go on and on for him. I'll now pass over to Dr. Sekbe.
Thank you very much. Is this working now? Great. I'll try to speed up my presentation this afternoon. It's probably longer than it should have been, so I'll skip through many of the slides and try and get to the main point of it. But firstly, thank you to the organizers for inviting me to present. It's been really interesting so far. So the title of my presentation is Digital Public Goods and Health Service Delivery. So I'm going to be trying to describe for you one of the research agendas that we followed over almost 15 years at this stage, and what we've uncovered, and it's mostly through field work, through working in the field, building open source software, delivering it into production, what we've learned from that, the challenges and the advantages that we see in it, and where we are now in this journey that we're following. So I'll be following that through. If I could just get the computer to work. Great. So just starting off to set the scene, so I'll whip through this very quickly. It's something we all know. Digital health is a key enabler of health service delivery, and this is something I remind myself every day. For the last 2 weeks, I've been in Ethiopia, and just seeing the adoption of digital health in Ethiopia, one of the favorite countries that I have to work in, is very rewarding, and to see the advances that they're making as a country in that. But of course, the key challenges we know: infrastructure, cost of appropriate software solutions, and then, as others have said, community-driven open source has been one of the strategies that countries have used to try and take advantage of digital health and overcome some of the challenges. And then the one that we are particularly focused on now at the bottom there, the success of digital solutions often limited by fragmentation and lack of interoperability between systems. We heard other speakers speaking about the DHIS2, which is an enormously successful piece of open source software. Of course, it needs to be applied correctly under the correct circumstances. But also it's part of an ecosystem. And what we are seeing at the moment, I believe, is that the movement from small isolated applications of digital technology to national level systems at scale, requiring interoperability and integration. So that's the primary challenge that we've been working with in the last couple of years. And this diagram over here shows the work that we did in the first half of the 15 years. So we were one of the founder members of another community-driven piece of open source software called OpenMRS, the Open Medical Record System. So that started out, if you looked at this map 15 years ago, you would have seen one little dot over here, which was where we started it in Cape Town. With 5 community meetings, with getting small amounts of donor funding from the Canadian IDRC. We're talking about 200,000, 300,000 Canadian dollars to start something. And this is, I think, one of the successes of open source, is that it's used all over the world now, from a relatively modest investment by a seed donor. And now it's used in many, many countries. So it was from that experience that we decided the next challenge that we wanted to research and develop was interoperability. And that was investigating the feasibility of health information exchange as a potential key technology for interoperability in low resource settings. So we heard other speakers mentioning earlier today, this important perspective that whatever we develop needs to be focused on low resource settings and how things work in that environment. And it was to leverage the experience in the OpenMRS community-driven open source solution, and to see if we could replicate that for health information exchange and do something towards interoperability. And then, of course, scale the system to a global digital public good. So what we've seen in the open source world at this stage, after 15 or more years, is the registration of digital public goods, so that we can address some of the concerns that some of the other speakers today spoke about, is how do we evaluate the open source solutions that are out there? How do we understand what works and what doesn't, and under what conditions? So that's the task that the Digital Public Goods Alliance is taking on, and is trying to do something in that regard. So what we did is, this is a picture, a diagram, which just basically shows our first stab at creating health information exchange for low resource settings. You can see it makes use of open source technologies like open source. In fact, it's built completely out of open source. This was an interoperability solution which we got from Canada, from Mohawk College in Ontario. And then these were different other pieces of open source software that we essentially combined. We used standards, international standards from HL7 and IHE, in order to construct essentially a small health information exchange. Well, it turned out not to be so small because it became the Rwanda Health Information Exchange. So implemented at a national level in Rwanda, still not at the level that we would like to see it being used, and many of these components have been switched out. But essentially it was, I think, a seminal achievement to have implemented a health information exchange in Rwanda, and which is still being developed out today, and using the key piece there was open source technologies. So that was the first result that we had from trying to take the architecture of a health information exchange and implement it in low resource settings. One of the side effects of that was to develop another piece of open source technology called the OpenHIM, the Open Health Information Mediator. That is something that we did as GEMBI, with the, which is a South African non-profit company, in collaboration with the University of KwaZulu-Natal at that time, and then later the University of Cape Town. Also busy being registered as a digital public good. But one of the key pieces of that interoperability architecture, and we focused in on this because it's the enterprise service bus that really powers the health information exchange. And the rest of the work that I'm describing today really has followed the development of the OpenHIM. So after having been developed and implemented as a core part of the Rwanda Health Information Exchange, we built on that, those early experiences into working with others, building out the community aspect, because we believe that open source is really important, is only really important if it's community driven. This is one of the key requirements for it to become sustainable and for it to actually reach scale in countries. So a movement which came out of that early Rwanda work is now called the Open Health Information Exchange, which is a global collaborative of organizations working at taking that early architecture that we implemented in Rwanda and expanding that out. So we showed and demonstrated that this could address the interoperability challenge that was growing alongside all of the growth of all of the small open source softwares that were being implemented. And this was now developed into a standard architecture which was now being curated by this community. And this is the interoperability layer, the piece that's addressed by the OpenHIM. So the OpenHIM, we've continued to develop that and implement it, and in a number of different countries, and grow it out as open source software. I'm going to show the slide here. Please don't worry about the detail. It's really just to show that this is what it looks like now. So it used to be just one piece, and if you're really interested, there it is over there. But as we're saying, what's the challenge now in low resource countries is there has been, and we'd still like to do more of a study on this, but there's been enormous adoption of digital technology. A lot of open source solutions have been implemented, whether it's DHIS2 or SORMAS or ComCare or whatever. The countries have a lot of software out there, and these are all open source components. All of these are open source, and they can be put together into what is actually an enterprise scale system. So if you look just over here at Kafka, this is a very mature open source technology, a messaging bus, which allows us to take messages at national scale. So you're talking about Nigeria, Indonesia, hundreds of millions of people passing patient-identified information through a national system in order to register patients and to provide care at a national level. You need systems at this kind of scale. And I'm saying that our research is showing that you can do this in Africa, and you can do it in a sustainable way. So at this moment, again, I wish I had a nice map on this. I was trying to draw it, but I couldn't get to it. But at the moment, we have known implementations of the OpenHIM and the HIE in at least 8 African countries. 2 weeks ago, we held the Open HIE annual community meeting in Malawi, and many, many countries were there presenting their use of the architecture and the various components. And So at least we know of at least 8 African countries that have adopted it. It's being trialed in Indonesia at the moment. But this is a key piece here. Implementation has been challenging. So that is something that we're applying our minds to now and trying to figure out during the next phase of trying to develop out these key technologies is how do we assist with implementation. We've got some clues here today around capacity building, skills development, communities of practice, etc. Just to say some of the challenges that are emerging, sustainability models, we've all spoken about that. That's clearly a challenge with open source, which is ultimately how do you finance that in the long term? And I think it's something really critical that we need to get to because, as I've mentioned, a lot of countries are moving to national scale implementations built on open source software, which is maintained by, well, to be honest, fairly suspect business models. University of Oslo and DHIS2 is great. NORAD have been funding them for forever with vast amounts of money. But a lot of the open source software that are doing great jobs on the ground are not funded that well. So is that a sustainable business model, or should we be looking at something different? Governance is becoming really, really important. And I think it's on my next slide here. I'll just skip to that quickly. This is the POPI Act in South Africa. There's GDPR in Europe. We need to start thinking about that because a lot of these systems, when it's implemented by country, there's no contract between the country and the person and the vendor. So what does that mean in terms of liability? You know, who owns the data? So there are a lot of issues there. So again, from it, I just think they are challenges that need to be looked at. What's super encouraging as well is we worked on a project over the last 2 years, which is based also, I think, totally in line with this work, is to produce health information exchange guideline and standards, which was developed by the Africa CDC and adopted by the African Union. I mean, this is a seminal document, policy that's out there, because what this is addressing things like cross-border data sharing. So when we talk about global health security, pandemic preparedness, like what are we going to do about the next wave of COVID or another SARS type virus coming out, or a zoonotic crossing that we don't know yet. This kind of guideline is going to help us, Africa as a continent, respond in a more timely fashion. So I won't go into that more. We've done some work customizing this for Ethiopia, and we hope that this will be adopted soon. Nigeria is doing it, and there are other African countries. And I think this is where it starts. We need a governance framework. And then inside there are the standards and all of the technologies that can be mobilized so that we have a quicker response. Sorry, I'll be very quick now. Just to say the most interesting work we're doing at the moment, which is related to the public health emergency operations centers that we heard earlier, which often are I was there last week in Ethiopia, watching the FIOCs respond to the cholera outbreak in Ethiopia at the moment, and it's wonderful to see how a whole group of 30, 40, 50 people, public health professionals, are all gathering data from response officers out in the fields, etc., and bringing all of that together in order to provide a coordinated public response in Ethiopia to a public health outbreak. And that's what motivates me as we go along. And we're thinking about how AI can really be used in future in order to support those kind of people on the ground. At the moment, when you look at the kind of dashboards that they are producing, it's all about response. It's all about up to now. There's very little happening in terms of prediction. Like, we should be able to be adopting the One Health policy of the World Health Organization and all of the pandemic work in order to help us prevent the next outbreak and predict the kind of environmental conditions that are going to potentially result in another zoonotic crossing or whatever else. So I'll leave it there just to say that's all of this data integration of work, of course, empowers this because it's all based on data. So at the end of the day, once you have the data, once you have the interoperability, once you have the standardization, this is what you can start doing. You can really start looking at AI, machine learning, digital twins, whatever your fancy is. And then just to credit all the people in the group that I work with in Jembe at the University of Cape Town and the Regan Street Institute in the United States. And then just a last slide just to say that the way that we're working with many of our African colleagues is through these kind of networks. And we call it an ecosystem model. So last week I was at the University of Gondar in Ethiopia, and then and what we do is we create nodes around this, which are working through NGOs that are doing the work on the ground, the universities that are doing applied research, and then the institutes that are doing the blue sky research. And I firmly believe that, you know, a lot of innovation can come out of Africa because we have all of the opportunity and all of the wherewithal to do it. So, last slide is just to thank everyone for listening and for inviting me to speak today. Thanks so much. Thanks.
Thank you very much, Dr. Chris. We've heard and listened to the 5 presentations from e-health leadership to best practices and lessons. We also learned about how to implement for emergency in the COVID-19 pandemic. We also heard about factors affecting the adoption of telemedicine all the way to digital public goods and health service delivery. He's also given us, the last presenter, some food for thought, issues pertaining to liability, who owns the data. And that's something within our countries, our governments, we need to take into serious consideration. I'll open the floor for questions to the 4 presenters. We already had a chance for the first presenter, now the remaining 4 presenters. The questions you took note of. You just mentioned the questions directed.
This is a question for Professor Mohammed. When you look at the outcome of the research in these different countries.
We'll get the questions and then I'll give a chance of presenters to respond. So just take note of your questions. Okay. Yeah.
Okay. Different countries, when you look at these different countries in terms of outcomes of or best use of technology for idioms, have you seen any policy impacts, different policies resulting in different outcomes from these different countries which you have seen, if you have actually looked at those? It might not really be the area of interest, but thank you.
Okay, thank you. More questions?
Hi there. My name is Carl. Thank you very much to each one of the speakers for wonderful talks. The overarching theme that I noticed is that these open source, whether it's private, whether it's public, these open source health collection apps or software or systems are very disjointed. And Chris, I think you mentioned the interoperability is actually essential. Now, I wonder, at a fundamental level, is this because programmers, I don't know if there's any programmers in the room, but I don't understand enough about it, but is this because programmers are not talking to one another and each person wants to feel confident that they've built their own system, and now these systems must all talk to one another, and we end up with thousands and thousands of programmers who do one little bit here and one little bit there. That slide that you showed, Chris, with all of the different systems talking to one thing and one there, it's like, what are we doing? We have to think about it as a one system. Your thoughts on that?
Okay, thank you so much. That's a quite packed question. More questions?
Yeah, my question goes to Dr. Chris. Talked about cross-border healthy data exchange, which is really quite an issue, because when you go to specific countries in Africa, you realize things are so difficult. Even for the researchers, you try to think of a problem which is real, but when you remember the policy issues and the challenges, you realize that the implementation, there's a problem. It's not implementable. PhD students, they have come up with their, topics. They have been shut down because it is not visible to implement such an idea, given the governance issues and all that. Now, you have talked about a possibility of having a standard framework for Africa to be able to exchange healthy data, across the border and all that. But what is the African Union doing to ensure that every African country cooperates to ensure that then we are able to get there the soonest possible? What is exactly the African Union doing?
Thank you. One last question before they start responding. Any question at the back? Okay.
Thank you, Chair. Thank you, Presenter. I just want to comment a bit of a question. My name is Rui from Central University of Technology. Chris, the last presenter, indicated and making an emphasis in terms of the data governance. Also, if I pick even on the previous speaker, the one was presenting with the COVID and the pandemic, I just joined later. So that speaker also indicated problems that were related to data quality and some of the information that is incorrect and all that. And now, if we are looking in terms of the artificial intelligence, where now we are moving to another platform that is between the data and the synchronization, I am picking that the previous person that has just made a comment now, he said that he's not knowing exactly whether the problem is with the developers that are sitting in silos where they are not coming together and come up with actual solution that is going to sort the problems. But what I want to raise, whether is there any background at the work, whether maybe Chris is aware of it, especially in terms of data governance, because all this we are pointing towards data, even if it's coming from the AI side, it's coming from the data, even if it's coming from the quality, it fits to one element which comes to the data. So a framework looks like, or data governance that will fit into abroad, even when we are sharing the information in other countries within South Africa and outside South Africa, if we can have a framework that is clearly, because it will also cover the POPIA Act, because you find out even POPIA, because it touches the data that is being shared within this platform, whether it's a health platform or whether it's what platform is digital. So is there any framework that in this group of research that you are working on it, Chris, that is touching all these areas, POPIA and quality and the POPIA quality and the data framework? Thank you.
Thank you so much. I'll let Dr. Chris start responding his set of questions.
Thanks very much. So just in terms of the programs, I mean, that is a part of it. But I think the reason why you have all the different open source softwares is because health is managed in a programmatic type way. So you have a maternal, newborn and child health program, you have an HIV program, you have a TB program, and these often will, and they will commission software to be developed. I was part of that. I developed South Africa's national TB control program 15, 20 years ago. And that specifically was used by the National TB Control Program in South Africa. And then it was sort of adopted for HIV. But the maternal program is very different. So you get all of these different softwares springing up. And I was going to ask the colleague from Kenya whether they tried SORMAS, for example, for COVID. Might have been an alternative choice to DHIS2 because it's a specialist for outbreaks and vaccinology. So that's how people design the software. Whereas, what I'm advocating is, we need to think of One Health, an enterprise approach. And, One Health is more than just the health system. If we're talking about global health security, we need to be thinking of animal health, environmental health, etc. So, it's more at an architectural design level. So I think, and that's what we're seeing emerging now in terms of the way that the software is being developed. And then just in terms of the cross-border, I think the AU has taken that step. It's fantastic. They've got the policy out there, and they've put that peg in the ground, and they've said, they're looking at data governance. And one of the main decisions there was to say this is meant to be implemented by member states. So as I've said, I worked on the AU document, as well as helped prepare a version of that for implementation in Ethiopia, which is going to help them harmonize their policy, their standards and data governance. There are a whole lot of sections in the policy itself, locally in Ethiopia, but align it with the AU. So if all of the member states do that, then you've got a continental framework which has been implemented continentally. And then we can say if we adopt HL7 FIRE, let's say, for example, for interoperability in Ethiopia, then Nigeria can consider adopting the same. And then at least when you have sorted out the legal requirements for data sharing, at least the technical barriers are not there, because that has been, at least some progress has been made on that. And then, just in terms of data governance, I think it's data governance. There are templates and frameworks for that. It's quite easy to get a data sharing agreement or a data use agreement template that you can use. And then what's more difficult in my experience is to understand what within a government department or a national Ministry of Health, how the power and the ownership of the data is actually dispersed among the different departments within the Ministry of Health. I know we all say, well, the user owns the data. We know that, but it's not actually quite that simple, because when a department or a Ministry of Health compiles that data into digital format, many lawyers will tell you that there's a degree of ownership that the compiler of the data has. And in South Africa, like with GDPR, you have the controller of the data. So it's a very complicated area. And in countries that have a federalistic type structure, you find that one division in South Africa, I don't want to get myself into trouble here, but you might call that a province. I don't know, hope that don't get my head chopped off of that. Might have a degree of ownership which is different to the National Ministry of Health. So, yeah. And I think that document that the AU's put together tries to recognize that. Thanks.
Thank you so much. Prof?
I have only a question about policies. So within the Beta eHealth project, we build 2 registries regarding or collecting solutions and official document policies, strategies, especially or particularly for the 4 participating or partner countries, Ethiopia, Ghana, Malawi, and Tunisia, but also African countries. These registries are open, so you can access them, and many data are already collected. And before putting them publicly, we evaluate the collected data regarding some criteria about quality of data, completeness, and so on. And now we are collaborating with DHE from World Health Organization in order to combine both databases, because they also, in the DHE Digital Health Atlas, they collected also policies, documents, and strategy documents, as well as solutions. So so you can access to this data and collect these already collected policies in African, particularly African countries. Yeah, please.
Thank you so much. Madam, would you like to comment on his question?
Oh, yes. I think the issues that are being raised about data governance is a key challenge in most of our countries. And it's not just about the developers. Even the policies within the countries themselves, the policies, you'll find that one policy is conflicting with the others. And I find that as much as we are giving the technical capacity building, I believe governments or leadership within the Ministry of Health need also capacity building in terms of how to standardize all these digital platform, integrate them, ensure that there is data that can be collected. And as in the case of my presentation, suppose we have another emergency. If we don't keep engaging the stakeholders, who include the developers, the governments, departments, and all the other stakeholders, we will still face the same challenges. So leadership for data governance is still a key challenge which needs to be addressed. Thank you.
Thank you so much. Just to point out that it's quite interesting because from the project which Prof mentioned, his research could have been could have used the e-registries from Better e-Health project as a source of data for policies and strategies. So for the next version, maybe you can visit that site. Just to complement the question which was asked about programmers, assuming that we had, bearing in mind that programmers get requirements from the clients, assuming that there is quite an agreement on programmers' front, we also have another aspect who is funding that particular project. And chances are who is funding would also have a hand on deciding which systems, what should happen. So what's your take on that, considering that the different stakeholders, different interests in the same space?
I mean, that's absolutely the case. That's why, a lot of the applications are directed at HIV, because that's where a lot of the funding for digital health comes from. And but of course, there have been big efforts by the US government, among others, PEPFAR, who are funding a lot of the key digital health development to broaden that into general health system strengthening. So that's why I cited them on my slides, because they funded that work to try and, recognizing that a lot of the systems are siloed at this stage, is to how to grow them out into more generalized solutions, which also makes it easier for countries to adopt them. So I think the two go hand in glove. So I think it's a normal trend. There was a first generation, and a lot of open source software solutions were delivered. Now the second generation is looking at interoperability, how to get them all working together in a harmonized way. And then the third generation will probably look more at the sort of data that's coming out of these systems. That's just the software engineering kind of dimension.
Thank you so much. Once again, thank you so much, our 5 presenters. Let's give them a big round of applause. And you would have noted that some of the presenters have got vast networking cycle and vast experience. Let's utilize that and network with them for future collaborations. Thank you.
Thank you.
We'll go for coffee break and then move on to the next sessions.